terrorism, mass casualty, and disaster nursing. Many resources are available at the state, federal, and local levels to assist in the management of mass casualty incidents, disasters, and emergencies. An MCI is defined as any incident that causes a large number of casualties to the extent that necessary resources become too scarce. When resources to care for casualties become scarce, the greatest good for the greatest number of patients becomes the mode of operation. Local communities must be prepared to act in isolation and provide competent care for up to 5 days before federal or other state resources may become available. Disasters are categorized by type based on anticipated use of resources and incident duration. See Chart 73-2. A list of local resources with specific instructions about how and when to contact these agencies or organizations should be readily available to local disaster planning committees and frequently reviewed by those committees for necessary updates. A disaster response strategy cannot succeed without appropriate physical assets and a staff trained and prepared to carry out the plan. Assets such as increased security, stockpiles of equipment, medications, planning drills, and training are essential. Hazard vulnerability assessments should be performed to identify potential and actual threats that include a particular facility and community. Mutual aid agreements among various communities must take these vulnerabilities into account. Successful execution of a response plan is based on knowledge, confidence, and readiness. Federal agencies that may provide resources in response to a mass casualty or a disaster include the Department of Health and Human Services, the Department of Justice, the Department of Defense, and the Department of Homeland Security. Each of these federal departments oversees hundreds of agencies that may respond to MCIs. For example, personnel from the Federal Bureau of Investigation, the Federal Emergency Management Agency, the Centers for Disease Control and Prevention, and disaster medical assistance teams are a small sample of agencies capable of responding to disasters. Some state and local agencies may be branches of the same agencies already listed. Example, the CDC and the FBI. Other state and local resources may include the American Red Cross, poison control centers, and other local volunteer organizations. Many state and federal task forces have been developed to assist in the development and improvement of civilian medical response to chemical and biological terrorism. The Incident Command System is a management system designed to enable effective and efficient domestic incident management by integrating a combination of facilities, equipment, personnel, procedures, and communications operating within a common organizational structure. ICS is normally structured to facilitate activities in 5 major functional areas: command operations, planning, logistics, intelligence and investigations, finance, and administration. It is a fundamental form of management with the purpose of enabling incident managers to identify key concerns associated with the incident, often under urgent conditions, without sacrificing attention to any component of the command system. Healthcare facilities are required by the Joint Commission to create a basic plan for emergency preparedness and to practice this plan at least twice a year. Before the basic emergency operations plan can be developed, the Planning Committee of the healthcare facility first evaluates characteristics of the community to identify the likely types of natural and man-made disasters that might occur. This hazard vulnerability analysis process is the responsibility of the local healthcare facility and its safety committee, safety officer, or emergency department manager. Multiple factors influence a facility's ability to respond effectively to a sudden influx of injured patients, and the committee must anticipate various scenarios to improve its preparedness. The essential components of the emergency operations plan include the activation response of a healthcare facility defines where, how, and when the response is initiated. The internal-external communication plan is critical for all parties involved, including communication to and from the pre-hospital arena. A plan for coordinated patient care is determined for organized patient care into and out of the facility, including transfers from within the hospital to other facilities. A coordinated security plan involving facility and community agencies is key to the control of an otherwise chaotic situation. Resources outside of the facility are identified, including local, state, and federal resources, and information about how to activate these resources. People management includes strategies to manage the patients, the public, the media, and personnel. Specific areas are assigned and designated person, and a designated person is delegated to manage each of those groups. A data management plan for every aspect of the disaster is created to save time at every step. Deactivation plan of the response is as important as the activation of the plan. Once a disaster plan has been activated, the demobilization plan should be implemented as soon as possible. Any post-incident response must include a critique and a debriefing for all parties involved, immediately and again at a later date. Practice drills, commonly referred to as tabletop exercises that include community participation, allow for troubleshooting any issues before a real-life incident occurs. Food and water must be available for staff, family, and others who may be at the facility for an extended period. MCI planning includes such issues as planning for mass fatalities and morgue readiness. A strong education and training plan for all personnel regarding each step of the plan allows for improved readiness and additional input for fine-tuning of the disaster plan. As noted previously, hospitals are required to periodically hold disaster drills. Patient tracking is a critical component of casualty management. Disaster triage tags, which are numbered, are used to communicate patient information. This information can and does include triage, priority, name, address, age, location, and description of injuries and treatments or medications given. The tag should remain with the patient throughout the incident. Triage is the sorting of patients to determine the priority of their healthcare needs and the proper site for treatment. Triage occurs multiple times during an incident. It is initiated on the scene of the incident and can occur multiple times throughout the continuum of care. Triage is where a healthcare worker assigns a priority and allocate the most resources to those who are the most critically ill. For example, under ordinary circumstances, a young adult who's had a chest injury and is in cardiac arrest would receive advanced cardiopulmonary resuscitation, including medications, chest tubes, intravenous fluids, blood, and possibly emergency surgery in an effort to restore life. However, in a disaster, when healthcare providers are faced with a large number of casualties, the fundamental principle guiding resource allocation is to do the greatest good for the greatest number of people. Decisions are based on the likelihood of survival and consumption of available resources. Triage categories separate patients according to severity of injury. A special color-coded tagging system is used during an MCI so that the triage category is immediately obvious. There are several triage systems in use across the country, and every nurse should be aware of the system used by their facility and community. The most widely used system consists of 4 colors: red, yellow, green, and black. Each color signifies a different level of priority. Refer to Table 73-1 for a description of each colored category. Internal problems can and will arise during a disaster or mass casualty incident. Each facility must determine its minimum supply list based on its own needs assessment. Information should be available about stocking or restocking any of the basic and special supplies, how those supplies are requested, and the time required to receive those supplies. Communication within the vast team of disaster responders is paramount. However, effective, informative communication with the media and worried family members is critical during any disaster or mass casualty incident. Although the media have an obligation to report the news and can play a significant positive role in communication, the number of reporters and newscasters and their support teams can be acute, possibly compromising operations and patient confidentiality. The disaster plan should include a clearly defined process for managing media requests, including a designated spokesperson, otherwise known as the Public Information Officer, a site for the dissemination of information, and a regular schedule for providing updates. No media should be allowed access to patient care areas. Friends and family members converging on the scene must be cared for by the facility. The Public Information Officer's role is to provide direction for the families and provide them with information as it becomes available. They should not be in the triage or treatment areas, but in a designated area staffed by available social workers, counselors, therapists, or clergy. Access to this area should be controlled to prevent families from being disturbed. Nurses make up the largest component of the healthcare workforce across the globe. The role of the nurse during a disaster varies. Nurses may be asked to perform duties outside their areas of expertise and may take on responsibilities normally held by physicians or advanced practice nurses. For example, a critical care nurse may intubate a patient or even insert a chest tube. A nurse may perform wound debridement or suturing. A nurse may serve as a triage officer. In these situations, it is imperative that nurses strive to maximize patient safety and be aware of state regulations related to nursing practice. Disasters can present a disparity between the resources of the healthcare agency and the needs of the victims. This generates ethical dilemmas for nurses and other healthcare providers. The following list outlines a number of those issues. Of those listed, confidentiality, rationing care, and resuscitation will be the hardest ethical dilemmas healthcare providers will face during any mass casualty incident. Although most people pull together and function well during a disaster, both people and communities suffer immediate and sometimes long-term psychological traumas that most often relates to fear and anxiety. Common responses to disasters include anxiety, depression, impaired performance, interpersonal conflicts, post-traumatic stress disorder, gastrointestinal disturbances, skin rashes, and substance abuse. Nurses can assist victims of disaster through active listening and providing emotional support, giving information, and referring patients to therapists or social workers. Another component of preparedness and response involves the protection of the healthcare provider by additional personal protective equipment, or PPE. The purpose of PPE is to shield healthcare workers from the chemical, physical, biologic, and radiologic hazards that may exist when caring for patients who have been contaminated. The U.S. Environmental Protection Agency has divided protective clothing and respiratory protection into the following 4 categories: levels A, B, C, and D. Level A consists of self-contained breathing apparatus and vapor-tight chemical-resistant suit, gloves, and boots. Level B consists of high-level respiratory protection but lesser skin and eye protection. Also a chemical-resistant suit. Level C consists of an air-purified respirator, coverall with splash hood, chemical-resistant gloves, and boots. Level D is any typical work uniform. Levels C and D PPE are the levels most often used in hospital facilities. Protective equipment must be donned before contact with a patient who has been contaminated. An explosion may spread dangerous material. Therefore, a treatment of blast injuries must be anticipated and planned. A blast may result from terrorism, but can also occur anywhere at any time if the right or wrong circumstances come together. Common examples would include natural gas, gasoline, welding gases, explosions both natural and gasoline, welding gas explosions, and electrical explosions. The actual blast that occurred during the initial seconds of the bombing or explosion causes a pressure wave or primary blast wave. Injuries can result from the impact of the explosion, the primary blast wave, or shrapnel. Blast lung results from the blast wave as it passes through the air-filled lungs. The result is hemorrhage and tearing of the lung, ventilation perfusion mismatch, and possible air emboli. Typical signs and symptoms include dyspnea, hypoxia, tachypnea or apnea, a cough, chest pain, and hemodynamic instability. Rupture is the most frequent injury after subjection to a pressure wave. Because the tympanic membrane is the largest is the body's most sensitive organ to pressure, there is an increased incidence of tympanic membrane rupture when a blast occurs in an enclosed space. Signs and symptoms include hearing loss, tinnitus, pain, dizziness, and otorrhea. Other ear injuries may include ossicular disruption and impaction of foreign bodies. Blast abdomen may be evidenced by abdominal hemorrhage and internal organ injury. The typical signs and symptoms of internal abdominal injury can include pain, guarding, rebound tenderness, rectal bleeding, nausea, and vomiting. Head injuries are typically minor, but those that are severe result in the majority of the post-blast deaths. These injuries can occur without a direct blow to the head and may result from the blast itself, building collapse, or flying debris. Concussions commonly occur post-blast, and the usual follow-up evaluation and treatment for post-concussion syndrome is indicated. Biologic weapons are weapons that spread disease among the general population or the military. They can be used for sabotage, such as food or water contamination with a small target area, or may be used by global terrorists with intentions to enable global objectives. Biological agents may be delivered or spread in a number of ways. Because of modern travel, spread of infection may occur in areas thousands of miles apart. Healthcare providers need to be aware of potential signs of biological weapons dissemination. Making diagnosis difficult, signs and symptoms are similar to those of common disease processes. Isolation practices depend on the infecting agency, so nurses should always use standard precautions. Some agents require transmission-based precautions, and terminal disinfection and disposal of waste depending on the infecting agents. Anthrax is a serious infectious disease caused by gram-positive rod-shaped bacteria known as Bacillus anthracis. Anthrax can be found naturally in soil and commonly affects domestic and wild animals around the world. As an aerosol, anthrax is odorless and invisible and can travel a great distance between disseminating. Hence, the site of release and the site of infection can be miles apart. Inhaling anthrax results in severe clinical manifestations. Its symptoms mimic those of the flu, and usually treatment is sought only when the second stage of severe respiratory distress occurs. Antibiotic therapy does not halt the progress of the disease. At present, penicillin is a primary intervention. However, strains of penicillin-resistant anthrax are thought to exist. Smallpox is classified as a DNA virus. It has an incubation period of approximately 12 days. It is extremely contagious and is spread by direct contact with clothing or linens or by droplets from person to person only after the fever has decreased and the rash phase has begun. Aerosolization of the virus would result in widespread dissemination. It manifests with a high fever, malaise, headache, backache, and prostration. After 1 to 2 days, a maculopapular rash appears on the face, mouth, pharynx, and forearms. Patients receive supportive care with antibiotics for any additional infection. Households and nurses can be vaccinated within 4 days after exposure. Smallpox sores appear all over the body at the same time and all look the same. They present mostly on the face, arms, and legs. Sometimes they are present on the palms and the soles of the feet. Smallpox can and sometimes is confused with chickenpox. Closer inspection of the rash is a key indicator when differentiating between the two. Chickenpox sores show up at different times in different areas. Each pox tends to look different from each other. They are mostly on the stomach, chest, and back, and rarely on the palms or the soles of the feet. Nurses who have direct contact with patients who develop smallpox should be vaccinated as soon as possible. Effects are more apparent and occur more quickly than those caused by biologic weapons. Agents vary in volatility, persistence, toxicity, and latency. Limitation of exposure is essential with evacuation and decontamination as soon as possible and as close to the scene of the incident as possible. Vesicants such as lewisite, sulfur mustard, nitrogen mustard, phosgene can cause blistering and burning. They can also cause serious respiratory effects that can cause death. Decontamination with soap and water is essential to reducing further injury. Do not scrub or use hypochlorite solutions during the decontamination process. Eye exposure requires copious irrigation, and treatment for lewisite exposure is demercaprol, IV or topically. Nerve agents consist of sarin, soman, tabin, organophosphates, and VX gases. By mechanism, they inhibit cholinesterase, causing cholinergic symptoms progressing to loss of consciousness, seizures, copious secretions, apnea, and death. Treatment consists of supportive care, atropine, benzodiazepine, and pralidoxamine. Decontaminate with copious amounts of soap and water or saline for at least 20 minutes. Rescuers should blot, do not wipe. Plastic equipment will absorb sarin gas. Latency describes a delay between nerve agent exposure and the onset of clinical effects. Nerve gas or nerve agents have the shortest latency. Blood agents consist of hydrogen cyanide and cyanogen chloride. By mechanism, they directly affect cellular metabolism, resulting in asphyxiation through alterations in hemoglobin. They can be inhaled, ingested, or absorbed in the skin and mucous membranes. Blood agents leads to the respiratory muscle failure, respiratory arrest, cardiac arrest, and death. Rapid administration of amyl nitrate, sodium nitrate, and sodium thiosulfate is essential after patient is intubated and placed on a ventilator. Pulmonary agents consist of phosgene and chlorine. Both vaporize rapidly, causing pulmonary injury. They destroy the pulmonary membrane that separates the alveolus from the capillary bed, disrupting alveolar capillary oxygen transport mechanisms. Capillary leakage results in fluid-filled alveoli. Manifestations include pulmonary edema with shortness of breath, especially during exertion. An initial hacking cough is followed by frothy sputum production. Radiation exposure may occur because of nuclear weapon, nuclear reactor incidents, or exposure to radioactive samples. Exposure to radiation is affected by time, distance, and shielding. There are three types of radiation-induced injury. There are three types of radiation-induced injury: external radiation, contamination, and incorporation. External radiation is when all or part of the body is exposed to radiation. Decontamination is not necessary. It's not a medical emergency. Contamination is the exposure to radioactive gases, liquids, or solids. It requires immediate medical management to prevent incorporation. Lastly, incorporation is the intake or uptake of radioactive material directly into the body. These patients should be triaged outside the hospital. The floor should be covered, and strict isolation precautions should be observed to prevent the tracking of contaminants. Air ducts and vents should be sealed, and all waste is double bagged and labeled radiation waste. Staff should wear water-resistant gowns, 2 pairs of gloves, caps, goggles, masks, and booties. Dosimetry devices should be present during any radiation decontamination process. Patients are surveyed for radiation and directed to the decontamination area. Decontamination should always take place outside of the ED with a shower. All water, tarps, towels, soap, gowns, and patient belongings must be collected and contained. All patients are surveyed, resurveyed, and reshowered as necessary. Biologic samples such as nasal and throat swabs and blood are collected as soon as possible. With acute radiation syndrome, there are 3 categories of predicted survival after radiation exposure: probable, possible, and improbable. After decontamination, triage of victims at the scene is conducted using the routine system for disaster triage. Presenting signs and symptoms determine the potential for survival. Probable survivors have either no initial symptoms or only minimal symptoms. Example, nausea and vomiting. Or these symptoms resolve within a few hours. These patients should have a complete blood count drawn and may be discharged with instructions to return if any symptoms recur. Possible survivors present with nausea and vomiting that persist for 24 to 48 hours. Barrier precautions and protective isolation are implemented if the patient's lymphocyte count is less than 1,200 per cubic millimeter of blood. Supportive treatment includes administration of blood products, prevention of infection, and provision of enhanced nutrition. Improbable survivors have received more than 800 rad of total body penetrating irradiation. People in this group demonstrate an acute onset of vomiting, bloody diarrhea, and shock. Any neurologic symptoms suggest a lethal dose of radiation. These patients still require decontamination to prevent further contamination of the area and of others. Personal protection is essential because it is virtually impossible to fully contaminate these patients. All of their internal organs have been irradiated. Their survival time is variable. However, death usually occurs swiftly due to shock. This concludes terrorism, mass casualty, and disaster nursing.